including the common terms used to explain the pathophysiology. Part 1 ends with a description of the mechanisms of compensation. Heart failure is the predominant cardiac disease of industrialized nations. In spite of the major advances in treatment, it is increasing in incidence and mortality. This condition affects 1 to 2% of the general population, or approximately 4 million people in the United States. About 500,000 new patients present yearly. Heart failure is the most frequent cause of hospitalization in patients over 65 years old. There are nearly 1 million hospital admissions yearly. Who gets heart failure? Most often it is the elderly. It affects about 10% of the population older than 75 years. The relative rate of heart failure is higher in African Americans, Hispanic persons, and Native Americans, perhaps because they are more likely to have hypertension and diabetes.
What is heart failure? Am I having a heart attack?
It's not a heart attack. What it is that your heart is constantly pumping blood out into your tissues.
The failure can occur in one of two ways. Either the ventricles fail to properly fill with blood, or they fail to properly eject the blood. Because not all patients have volume overload leading to organ congestion, the term heart failure is preferred over the older term congestive heart failure.
How did I get this?
Well, the most common cause is pulmonary artery disease.
Nearly every form of heart disease can lead to heart failure syndrome. Valvular disease, cardiomyopathy, myocarditis, endocarditis, congenital heart disease, and hypertension.
Many other diseases can lead to heart failure too.
It may be due to long-term systemic conditions such as diabetes, drug abuse, anemia, polycythemia vera, obesity, multiple myeloma, hyperthyroidism, and pregnancy. Sometimes it comes on suddenly with a myocardial infarction, dysrhythmias, pulmonary embolus, or physical stressors.
And sometimes it comes on because the person hasn't followed their doctor's advice as far as medications or diet.
Whatever the cause, heart failure develops from physical changes within the heart itself. A conceptual method of understanding heart failure is named after two 19th century physiologists, Dr. Otto Frank and Dr. Ernest Starling. The Frank-Starling curve graphically demonstrates the relationship between the strength of contraction of cardiac muscle fiber and the degree to which the muscle fiber is stretched by volume before contraction begins. The curve looks something like this. It starts with small ventricular volume and low contractility. As the volume grows, the contraction becomes more forceful. But there comes a point at which adding more volume does not improve output, and the pumping ability of the heart diminishes. The muscle fibers are much like rubber bands. If you stretch a rubber band just a little bit, it snaps back to its original shape when you release the tension. The more you stretch the rubber band, the greater the force with which it snaps back. As the heart chambers passively fill with blood during diastole, the cardiac muscle fibers stretch to accommodate the increasing volume. The more the muscle fibers are stretched, the stronger the contraction. However, there is a point at which the curve levels off. The heart simply cannot contract any more forcefully. Now, volume increases don't bring stronger contractions. They stretch the muscle fibers to the point of exhaustion and injury. Like the rubber band, heart muscle can be stretched too far, fluid overload dilates the ventricles. The elastic muscle fibers lengthen and stretch until they are damaged. Contractility weakens. The heart can't sufficiently eject the blood which is presented to it. As the pump fails, blood begins to pile up, stretching the cardiac muscle even further and causing more damage and more pump failure. Circulation slows down and the internal organs become congested with the backed up blood. The lack of oxygen stresses the already stressed heart muscles. Once begun, this cycle of overstretched fibers, decreased contractility, and depressed circulation can quickly lead to severe symptoms and then death. One of the earliest signs of developing heart failure is a sense of fatigue and general weakness.
So tired all the time. My arms, my legs, they're just absolutely like lead.
Dyspnea, or shortness of breath, progresses. It usually begins as exertional dyspnea, or activity intolerance.
When I sit around, I'm okay. But if I try to go upstairs, I can't even breathe.
Orthopnea is dyspnea that occurs when the person is lying down, awake, or asleep.
Do you feel better when you lie down?
Oh, no. Anything, strangely enough, is worse. I have to have at least 1 or 2 extra pillows.
Nocturnal dyspnea occurs as a sudden event when the person is sleeping.
Do you have any difficulty sleeping?
There are times when I can't breathe, and I wake up absolutely panicked. My throat is so tight, and it's so scary.
Finally, there is no position in which breathing becomes easier. Pulmonary edema congests the lungs, and the patient has persistent coughing and wheezing.
Have you noticed any swelling in your ankles or your feet?
As congestion increases and blood flow to the GI tract diminishes, there may be liver tenderness and abdominal swelling.
You know, I'm not hungry. I'm usually very nauseated, and I know I've lost weight.
Another symptom of heart failure is nocturia, or increased urination at night. Decreased cerebral perfusion also causes problems.
My head hurts. I have such horrible headaches. I can't think straight. I can't tell you how long it's been since I've had a good night's sleep.
Different terms are used to describe heart failure syndrome. They are describing different aspects of the same phenomenon from varying points of view. The concepts of preload and afterload focus upon the volume and pressure aspect of heart failure. Preload refers to the blood volume within the heart at the end of diastole, which is the relaxation phase of the heart. A lower preload is usually associated with a lower systolic pressure. When the cardiac muscle fibers contract, they push the blood out of the ventricles. However, the blood is not being pushed into an empty space. The aorta and the lungs already have blood in them, and this blood is pressurized from the previous heartbeat and from vessel wall tension. The ejected blood must have enough force to overcome this pressure before it can flow to the tissues. This back pressure is called the afterload. Forward and backward failure are functional descriptions. With forward failure, the heart fails to provide flow to the tissues downstream. Brain, heart, kidneys, skin, everything that needs new oxygen to stay alive begins dying. Backward failure looks at the tissues upstream of the heart, the ones that are getting congested with backed up blood. The lungs, liver, abdomen, and periphery are experiencing edema and pressure changes, as well as a decreased oxygen supply. Heart failure is anatomically described as left ventricular or right ventricular failure. In this view, each ventricle is linked to both its forward and backward tissues. With left ventricular failure, there isn't enough forward cardiac output to the body, and fluid is congested backward into the lung tissues. Right ventricular failure doesn't efficiently pass blood forward into the pulmonary circulation, and it allows blood to back up into the venous return system, congesting the liver, digestive system, and limbs. Most patients with chronic heart failure will have failure of both ventricles. Recently, it has become popular to describe heart failure as being systolic failure or diastolic failure. Systolic failure occurs when contractility is impaired and systole fails to push enough blood forward into the circulation. Diastolic failure occurs when relaxation is impaired, causing increased resistance to filling or lack of potential volume space. About 20 to 40% of all heart failure patients experience diastolic failure. Heart failure begins with an injury or stress that reduces its pumping efficiency. Stroke volume, that is, the amount of blood ejected by the ventricle with each beat, decreases. The heart responds by increasing the cardiac output. One way to increase cardiac output is to increase the stroke volume by increasing the force of contraction. This compensatory mechanism is called positive inotropy. Cardiac output can also be increased by raising the heart rate. This is called positive chronotropy. The muscle fibers respond to the stress by getting larger. This is hypertrophy, or cardiac remodeling. The end result of hypertrophy is an enlarged heart, cardiomegaly. Another way in which the body responds to decreased stroke volume is by activating neurohormonal systems. The sympathetic nervous system is especially sensitive to decreased cardiac output. The heart can receive sympathetic stimulation in two ways, directly or indirectly. Direct stimulation comes from cardioaccelerator nerves that exit the spinal cord at the T1 through T5 level and end at the sinoatrial and the atrioventricular nodes. These nerves secrete norepinephrine, which increases the heart rate and intensifies muscle contractility. Indirect sympathetic stimulation comes from the release of epinephrine and norepinephrine from the adrenal medulla. These circulating catecholamines increase the heart rate, the strength of contraction, and cause vasoconstriction that raises blood pressure. Other hormonal systems are also stimulated by a decreased cardiac output, especially the one regulated by the kidneys, the renin-angiotensin-aldosterone system. A decreased renal flow causes the juxtaglomerular apparatus to release the enzyme renin. Renin acts upon angiotensinogen to form angiotensin 1. The vascular endothelium secretes an angiotensin-converting enzyme, called ACE, to turn angiotensin 1 into angiotensin 2. Angiotensin 2 is a very strong vasoconstrictor that raises blood pressure, stimulates myocardial hypertrophy, and acts upon the adrenal medulla to cause the release of the hormone aldosterone. Aldosterone enhances the reabsorption and retention of sodium and water, increasing blood volume. The combined effects of the renin-angiotensin-aldosterone system lead to an increased blood volume, the preload, and an increased blood pressure, the afterload. In this program, we have discussed how the Frank-Starling curve illustrates the physiological principles underlying heart failure. We also looked at symptoms, common descriptive terms, and compensatory mechanisms. In Part 2, we will examine decompensation, diagnosis, and the American Heart Association's classification system for staging the severity of heart failure. It concludes with a brief discussion of current medical therapy for this condition.
Miss H, are you putting this video on canvas? You could have shared this video before the quiz.
You are correct.